We have two speakers, very smart speakers, two economists today, and they will address the topic from a different perspective. We will start with Fabrizio Mazzonna, who is playing at home, I would say, as his assistant professor, Swiss School of Public Health, assistant professor at Università della Svizzera, Italiana, and he is, as Luca Crivelli announced on Monday, the new scientific director of this school. So he's Italian, but he's really playing at home. He will focus on the health impact of the economic crisis. And then the second speaker is David Evans, and David is also an economist, although he has been working for the last 25 years at the WHO. He's currently the director of the Department of Health System Governance and Financing. And I'm very pleased to announce also that he's also kind of playing at home because he's leaving WHO and joining us at SSPH from next February. So Fabrizio, please.
So thank you, Fabrizio. Good morning, everybody. As before anticipated, in this talk I'm going to discuss about the health impact of the, so basically the effect of the last recession on health. At least I will try to discuss about it since we are still looking for data and conclusive evidence from the health effect of the last recession. And so I will try to discuss more generally about the relationship between macroeconomic condition and public health. So I don't need to spend too much time saying that the last crisis, the financial and economic crisis started in 2007, 2008, was probably one of the biggest recession we have ever experienced after the Great Depression. And the households were affected in several different ways by unemployment, loss of income, drops in wealth, and so we might expect some negative effect also on health. And on top of that, we have the recent sovereign debt crisis, in particular in Europe, and we might expect also effect by the cuts in government expenditure, and something that probably David Evans is gonna discuss later. So also cuts on health budgets. And so the first central question that I would like to address today, but I have to admit only partially, is have the Great Recession affected the public health? And the second question is a more general question about the relationship between economic cycle, macroeconomic condition, and health, and whether we can learn something looking at past crises. So it's important to stress before going on that this talk is not going to be about two things. It's not going to be about the more general relationship between economic development and health. So I mean, I'm not going to discuss about general improvement, secular improvement in economic condition and its effect on health, because it's a huge issue and I have not time for discuss it, and also because it's very complicated. And I'm not going to discuss about at micro level what's the relationship between income and health, as before, complicated relationship, reverse causalities, potential unobserved factors. So in this talk, I'm going to discuss instead about what's the effect of temporary economic downturn, so temporary economic recession, and their effect on population health, trying to focus also on the last crisis. It's important to stress that at least this is a sort of outline of my talk. So this effect, the effect of the recession and in general of the economic cycle on population health, depends mainly on three factors. The first one is the level of economic development of a country. So I'm going to show you that if we focus on developing economies, it is completely different if we look at the effect of economic cycle on developed economies. Second, short versus long run. Short-run effects are easy to measure, but they are only short-run effects. So long-run effect might be completely different, but they are definitely very difficult to measure. And finally, it's important also to stress that the intensity of the crisis matter. So from this point of view, I'm going to show you that the last recession is somewhat different. So probably looking at past crises can only partially help us to identify the potential negative effect of this recession on population health. And so I start direct with the first point. So I said before, the level of economic development is particularly important in order to determine whether the effect of the last recession is negative and how negative. So how big is this effect? So we know, for instance, that in the case of developing economies, there is quite large evidence on strong negative effects of recession on public health, while if we look instead at the evidence for developed economies, the evidence is the opposite. So in the short run, you know, for instance, that mortality increase with economic booms, and mortality usually decrease with economic recession. That is somewhat counterintuitive, but I'm going to show you why. And among the potential explanation for this different evidence between developing and developed economies, I decide to point out on three potential explanations. First, in developed economies, we have well-developed social safety net that may prevent the adverse effect on health, the presence of the so-called welfare state that can somewhat help. Malnutrition and risk of poverty are marginal phenomena in developed economies. And finally, negative effect may appear only in the long run. And what I would like to stress that these effects are very difficult to measure, and something on which I will come back only partially later. So I would like to start with two examples, two from developing economies. There are several examples. These are very, very nice. One is from Russia, and it's a paper on Lancet on 1997 by Leon and co-author that focus on the recession that followed the collapse of the Soviet Union. And another example is a paper of Cutler and co-author on Journal of Public Economics that look at a series of recessions that hit the country during the 80s and mainly the 90s. So in the first case, Leon and co-authors show the increased mortality rates in Russia immediately after the collapse of the Soviet Union. And this is somewhat opposite to what they found in the period immediately before the collapse of the Soviet Union. So basically, before the collapse of the Soviet Union, mortality rates were decreasing in Russia. After the fall of the Soviet Union, mortality rates were instead increasing. And I'm sorry, this figure is not easy to see because the quality of the figure is not so high, but unfortunately it's a paper on 1997, so this is the best I was able to find on Lancet. So, but I try to help you with interpretation. These are mortality ratio. They are ratio because they compare the mortality rate, for instance, in 1994 with the baseline period, so 1984, or 1987 with the baseline period, that is 1984. And so they are by gender, different curves, and by age. So these are the ratio at different ages, no? 1 to 4 and up to 80 to 84. So it's important the line of 1 here, that is means that the ratio is equal to 1. So if the mortality is on 1, means that mortality rates are stable. If the mortality curves are above the line of 1, means that mortality rates are increasing. If it is below the line of 1, means that mortality rates are decreasing. And these are all causes of deaths, and these are specific causes of deaths, such as, for instance, cardiovascular diseases or cancer. So here it's quite easy to see that mortality rates after the collapse of the Soviet Union were increasing. Before the collapse of the Soviet Union were decreasing. So there is a clear discontinuity in the trends in mortality rate in Russia after the collapse of the Soviet Union. And this is true not only for the general mortality, but also for other causes of death, like, for instance, cardiovascular circulatory diseases, but not for cancer, that represent a sort of placebo test. And Leon and co-author quite convincing show in their paper that one of the main reasons for this increasing mortality after the collapse of the Soviet Union in Russia was the increase in alcohol consumption. And so they clearly showed that most of this increase in mortality was due to the increase in alcohol consumption that followed the recession and the collapse of the Soviet Union in Russia. So not only we have an increase in alcohol-related mortality, but alcohol also depressed the immune system of many people, and so lead to other causes of mortality. This is for Russia. Another interesting case, as I said before, is Mexico. And I don't want to spend too much time on this table. It's important just to stress that Cutler and co-author look at the effect of three recession, 82-84, 86-89, and 95-96. And so what they found was an increase in mortality during these three recessions for very young, here, 0-4, and old people from 60 to 80 plus. So compared to, for instance, people, unaffected male in the age 30-44. So as I said, I don't want to spend too much time, but you can see that here from the numbers that there is a huge increase in mortality, around 10%, between 6 and 10% for very young and very old. The nice, let's say, feature of this paper by Cutler and co-author is that they were able to identify the channel for this effect. So why they observe an increase in mortality in Mexico after these recessions. And they evaluate 4 potential causes. The first one is obvious, reduced income. So if your income decreased because of the recession, you have less resources to use for goods that improve your health or, I don't know, better health insurance. Second, there is a reduction in public sector funds for the health system. Another cause that they consider is the fact that people have to, at least those that do not lose their job, have to work more, in particular in strenuous occupation, and this might have a negative effect on your health. And finally, this is also very smart, that they look whether the fact that the unemployment for male increase lead more women to work. And this reduces the informal care that women can provide for children and old age people. And actually what they found, the only 2 relevant channels in Mexico were the first 2. So reduction in income and reduced public sector funds for the health system. As I said, a point that probably David is going to address in the next talk. Unfortunately, when we look at developed economies, the evidence is still no. Unfortunately, so okay, it's the opposite. Yeah, unfortunately, I don't know. It's too normative. Maybe the initial evidence from a series of papers by Brenner's time series analysis during the 70s seems instead to support a negative effect of recession on health, like for developing economies. But this kind of evidence has been strongly criticized by many social scientists, in particular economists, because the results were too sensitive to the choice of the countries and to the time period, and on top of that, the methodology was not particularly robust. More convincing evidence is from a series of papers from Christoph Room, an economist, starting with a QJ paper of 2000, in which he shows evidence of the first convincing evidence of the effect of the recession and in general the economic cycle on health, with very surprising results. So Christoph basically shows that mortality is pro-cyclical. What means pro-cyclical? That means that when the economic activity goes up, mortality increases. So during economic booms, the mortality increases, and during recession, actually mortality decreases. Just to give you an idea, this is from a paper of Room of 2006, maybe on social science and medicine. I'm not sure about that. And these 2 lines are one the mortality and the other the unemployment rates. So when unemployment rates goes down, like here, mortality rate is high. You can see here, 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 here. So the 2 series have opposite movements. So once they are detrended. And why we observe such effect? One very simple explanation is that during economic booms, you have to work more, so the level of stress increases, and so there are more people that have heart attacks. And another important cause of mortality that increase are car and work accidents. So if you work more, you are more likely to have a work accident, in particular if you are working physical demanding jobs, and also car accident going to work. So if people don't work less, obviously this kind of accident are less likely. On the opposite side, we have instead the suicide and in general depression that usually instead increase during recession. But the overall effect is pro-cyclical. So even though suicide and depression tend to increase during a recession, there are other causes of death that decrease, such as heart attack, car and work accident, that are predominant. So this is the evidence we have so far on developed economies, on the relationship between economic cycle and population health. Moreover, the same room also use microdata at individual level, and they showed that higher unemployment is usually associated with a reduction in smoking, obesity, and increased physical activity, maybe because you are more time to devote to this kind of stuff, and improved diet. So I tried to use also an economic model, a quite simple economic model, and quite old, the Grossman model of 1972, to try to explain with an health model why we observe such strange results. So if we use the Grossman model, health is produced by lifestyle behaviors, human capital investments, so education, and of course stochastic shocks that might affect your health. And so during economic booms, leisure time declines, and so it is more costly to undertake what we call health-producing activities, because the opportunity cost of time increases, so you have no time to spend, for instance, for running. And on the other hand, health can be considered an input in the production function. In particular, for physical demanding jobs, you have to use your body. So if you work more, you depreciate your body faster. And so this explains why during economic booms, work accident increase. And with this evidence, I don't want to say, and this is something that I already said at the beginning when I said this talk is not going to be about. So this does not mean that economic growth has negative effect on health. This is in such a model permanently increasing income, so permanently increasing growth trends in structural growth are associated with improved health because the budget constraints is shifted out. And I'm focusing only on short movements in GDP or in unemployment. So I'm talking about temporary upturns or temporary recession. So I'm not talking about the secular trend in economic condition. I'm talking about movement of the GDP, small movement, so business cycle, not trends. And the second point I would like to address, as I said before, long-run effect might be different. So long-run effect might be negative and long-lasting. But the real problem is that they are very difficult to measure. So think for a while to the last crisis. So the crisis hit many countries around 2008, but it's very difficult to find a control group because at the end, all people were affected. People at different age were affected by this crisis. So even if you look at 10 years, 50 years after the crisis, it's very difficult to find a control group because all the people were affected. The only potential control group are people that have still to be born, no? At the end of the day. So long-run effects are very difficult to measure, and a tricky and smart way to look at long-term effect was found by Vandenberg and co-author in a series of papers, the first on American Economic Review in 2006. And what they do, they compare individual born and raised in good times, so during the economic booms, with people born during recessions. Of course, this is not a way to overcome entirely the problem. This is just a way to look at sensitive period of life in which probably the effect of a recession are more important. And so they basically use the cyclical movement in the gross national product of several countries, starting from Netherlands, and removing the secular trend. So just to give you an idea, this is the gross national product of Netherlands. This is is the American Economic Review paper of 2006. So it's the continuous line. You see the big movement. And they remove the trend, that is the dotted line. So what they do, they compare people born in a very close bandwidth, so very close cohort, and they compare, for instance, people born in this boom with people born in this recession. And so they try to compare their health, and what they found is it's quite interesting because not only they found an increased mortality in the first years of age that is somewhat expected, but they also found an increase in mortality after the age of 50, in particular increase of cardiovascular diseases. So these effects are not only short-run effect on the mortality in the first years of age, but they observe differences in health between people born in booms versus people born in recession after 50 years of age. So with an increase in cardiovascular diseases, for instance. And this kind of evidence can be consistent with the large and growing literature in economics and epidemiology that showed that negative long-lasting effects on environmental insults early in life, not only economic recession, they look also at World War II, for instance, the 1918 epidemic influenza, other disease, pollution, or let's say the Chernobyl fallout. And the idea behind this is the so-called Barker hypothesis, wide known among social scientists and epidemiologists. So according to this hypothesis, adverse influences early in life, and in particular in utero, may result in permanent psychological and metabolic changes that increase the risk of disease later in life, in particular cardiovascular diseases. And the idea behind this is quite simple. So the idea is that these negative health effects remain latent for many years, and they show up only after 50 years of age, when usually, for instance, heart diseases start to emerge, for instance, after the middle age. And so at the end of the day, so long-term effects are very difficult to measure, but we can say that, for instance, for particular period of individual life or particularly sensitive period, this long-term effect might be particularly negative. Finally, and I'm going to discuss some evidence also from the Great Recession, I'm going to discuss about the intensity of the crisis. So the point that I want to stress here is that small economic recession cannot be compared probably with the last recession. Last recession was so big, maybe only the Great Depression was bigger, and many European countries, for instance, are still dealing with its effect. Just to give you an idea, this is the GDP of several European and non-European countries from 2007 to 2013. Seems complicated, but the reality is very easy, because the 2008 is taken as the baseline. So the line of 1 means this is the level of the economic activity in 2008. And you can see that in 2013, most of the countries are still below the line of the economic activity of 2008. So you have Greece that is 75% of the level of the GDP of 2008, and many other countries like Spain and Italy are far below the level of the economic activity of 2008. And also countries like Germany and France that are above that line and are used to known as countries that perform better are just slightly above the level of economic activity of 2008. So this recession was particularly huge. And if we look at unemployment, the story is even worse, because unemployment levels increase in Europe, but also in the United States, in particular in some countries, like, for instance, Spain and Greece, where unemployment levels arrive to the level of 25%. I have no Italy in this figure that is from Stagler and co-author. For instance, in Italy, unemployment rate for the youngers arrived to 40%, 50% in Spain and in Greece. So with these two figures, I just want to stress that the last recession might be completely different from the past. So looking at the past probably can only partially help us to predict what are the effects of this crisis on health. As I said before, I show you some first evidence from the Great Recession. In a paper of mine with Bücher-Könen, we found for its negative effect of the 2008 and 9 crisis on self-reported health of people aged 50 to 65 in 10 European countries. So what we do here, we basically compare people across Europe and within the same country, and so we see whether people that live in a region of Europe more affected by the crisis are also the people that experience the largest drop in their self-reported health. And this is what we actually found. So in region where the crisis was particularly hard, we found a larger drop in self-reported health of the individual. And nicer evidence with a similar sample from the US, so people aged 50 plus, is the paper on Journal of Health Economics of McKierney and co-author that found an increased depression symptoms and antidepressant use immediately after the stock market crash in the USA of 2008. So these are very short-run effects, okay? And as expected, we have also large evidence on increase in suicide rates and alcohol abuse, and there are tons of paper now by Stagler and co-authors that look at this effect in Europe, UK, and US with a series of paper. I just report 3 of them, starting from 2009. So just to give you an idea, this is the change in suicide rate in Europe. And you can see that after 2007, for both the new European country and old European country, there is an increase in suicide rate. A more robust analysis has been implemented by De Vogli in Italy. What they do, basically they look at the suicide and suicide attempts in Italy, in some regions, and they made a out of sample prediction of the 2000-2007 trends, and they identify the excess suicide and suicide attempts as this shaded area. So you can easily see that after 2007 there is an increase in suicide and suicide attempt, and so they identify the excess as the difference between the observed number of suicide and suicide attempts and the predicted trends. So but with an out-of-sample prediction of the trend from 2000 to 2007. So this is the excess suicide that can be associated with the crisis. A similar exercise has been implemented, has been done also in USA by Reeves and co-authors. You can see that here the excess deaths are about 5,000 in the US in the period 2007-2010. So I think that I can sum up. So the effect of the economic cycle on health depends on several factors. So the stage of the economic development, it seems to be particularly important. So in developed economies, the effects are different from developing economies. We can observe usually only short-run effects, but when we are able to observe long-term effects, these effects are huge. But as I said before, it's very complicated because we need a proper control group. And the intensity of the crisis also may matter, so it means that the last recession may have larger effect with respect to previous recession. For this reason, conclusive evidence from the Great Recession is still lacking and involves only short-term effects. However, as I've shown so far, we already have some negative effects, mainly on mental health, that may have long-lasting consequences. Evidence from previous crises can only partially help us, and it might be relevant, this is something that probably will be addressed in the next talk, to evaluate the short and the long-run effect of major cuts in health budgets. Thank you.
Thank you very much, Fabrizio. And if there is 1 or 2 clarification questions, we can take them, or otherwise we move to David. Yes.
Okay, I hope it's better. If we want to look at the effect of this current recession, we have to measure the mortality of the generation that suffered from it. So we will measure the mortality of the people that lived it, right? So we cannot withdraw conclusions now. I'm not sure I understand correctly how we withdrew the conclusion about rise or decrease in mortality.
There is confusion because it's not easy to determine who are the affected and when we have to observe this increase in mortality. So there are some causes of mortality that can be observed already in the short run, like suicide or heart attack, but there are other causes of mortality that can appear only after 10 years. So the timing is crucial. So maybe there is confusion because it's very difficult to measure the effect. So for the moment, we can measure only those causes of mortality that can appear in the short run. So suicide, heart attack, car and work accident, this is the only thing that we can measure in the short run. If we've gone far away from the crisis, it's very complicated because it's the effect of this crisis, it's the effect of previous crisis, it's the effect of something else. So after 10 years, can you be sure that the effect is due to the last crisis or to the crisis that was before? So it's very hard from a methodological point of view to identify these effects. But you are right, it's complicated.
Okay, there is another. Luca wants to ask a question, and then we move to David.
No, first of all, I would like to thank you for the nice talk, and I think it's very thick. A lot of material was inside. However, there is, I think, a missing point that could be a confounder or could be maybe something that helps us to disentangle the problem. You haven't spoken about inequality. I just make an example. One of your first example was the Russia the collapse of the Soviet Union. And I'm not sure that the only thing that you observe there is an economic downturn. What we know is that, for instance, the Gini index increased a lot from the former Soviet Union and the past society. The question is, how in the literature is the issue of inequality or the impact of economic crisis in terms of inequality, how this could be an important argument to look more in depth into the problem?
So the first short, you want the long or the short one? Because the short one usually economists don't care about inequalities, and this is a bad point. Sorry, I'm joking. And no, in the case of Russia, it's very complicated because one can also think that it's a psychological effect due to the fall of the Soviet Union. In other case, is the recession that so maybe the increasing inequality is a channel. Okay, so I mean the effect is due to the recession. The recession implies an increase in inequality. So inequality in this case is a channel for the effect, but it's not always so easy to identify the channel. The only paper that I have seen so far is the Capita Paper, that was very smart and identified all the potential channels, and he was able to. So in that case, if you look at the cuts in health budgets following the Mexican crisis, at the end it's inequality, because the people more affected are people that rely on the health system. Yeah, you are right.
Okay, let's move to the next talk of David Evans on the implications of the crisis on health systems.
What I'm going to try and do is focus largely on the financial implications, particularly for health, of the recent crisis. Partly because crises start with money, although they don't end with money. As we've heard, they end up with consequences for people. It's partly also because it's easier to see the impact at the moment on some of the financial indicators and the financial flows, although not on others. It's not quite as difficult as trying to track causality in terms of changes in health outcomes, as Fabrizio has pointed out, is not easy. Fabrizio has also talked a little bit about, is this crisis different? And I think it is. I'll just go through a few reasons why it's different. I will look at the impact on health systems financing, largely on financial flows for health, but a little bit on efficiency, a little bit on out-of-pocket payments. And then I'll talk about things that are yet to be resolved, things that we don't know yet, and we need to keep an eye out for. In 2009, at the World Health Assembly, the impact of the crisis was just beginning to be felt. And there was great interest amongst all of our member states, 193 countries at that stage, were wanting to know what's going to be the impact on us. How's this crisis going to affect us? And so a little bit like Fabrizio did, we had a session where most countries attended, where we tried to look at, well, what's happened in recent crises. We didn't go back to the Great Depression. We just took the crises after 1990. And this is one of the slides that we used in that. One of the important things to note is people talk about global recessions. One of the most common definitions of recession is 2 quarters or 2 3-month periods of negative economic growth, or negative real economic growth, and inflation adjusted. And in all of these periods of recession before, or crisis before the current one, it's actually not been a global recession. There's been different sets of countries that have had negative economic growth. So that line, the dotted red line, is 0. Anything that comes below 0 is negative growth. And you'll see in this one, it was Africa, the African debt crisis, that was really important. Although all regions, there were blips in growth, but there was positive growth. Same thing happened for the next crisis, where it was largely Southeast Asia, a little bit South America. The next one was more South America. So in each of the periods of crisis, it's not all groups of countries that are affected. Now, one of the themes of what I'm going to say, and I'll illustrate it a little bit, is these sort of generalizations hide a lot of heterogeneity across countries. And in fact, one of the nice things about having people from a lot of countries in the room is that I think your experiences of what's happened to you in the crisis is also going to be something very useful in the discussion subsequently. So what we said was, well, in this crisis, it looks like the latest crisis is confined more or less to the high-income countries. That's what we said in 2009. Obviously, we were very interested in what that meant for the low-income countries, because most of our member states are not donor countries. They receive, a lot of them receive external aid. And so we tried to trace what happened to external assistance in previous crises to try and give us some idea of what might happen. The blue line is total external assistance. The red line is external assistance for health. Now, you might ask, well, how can external assistance for health get more than external assistance in total? And you just have to look at the different axes, the different scales of the axis, okay? So to get them both on the same graph, I've had to have different scales, but it's the trends that's important. And what we see is that in most crises, that particularly where the richer countries' growth falls, external assistance falls as well. But external assistance in health doesn't have to fall. It's a choice variable. What they decide to spend on is really important. We drew some other lessons, partly as a way of trying to tell countries or work with countries to make the right choices. Because many of these variables many of the things that have happened don't have to happen. Many of these things can be avoided if the correct policy is made. And so what we suggested, yes, external assistance doesn't have to fall. Domestic financing, and again, it's a little bit different this time because we're dealing with high-income countries. But in the past, it was lower-income countries, and often household spending on health has fallen, right? And that has often led to changes, switches from private sector use of private sector services to use of government services. So if government spending falls and people switch from using private services to using more government services, it puts extra pressure on governments during recessions. And so that's another thing that we said, well, you have to look out for. Domestic spending doesn't have to fall. Government spending doesn't have to fall. It's a choice variable. But make sure that you are aware of the fact that people might switch in countries where there's a significant private sector from the private to the public sector because they can't afford the out-of-pocket payments. And as we've seen in this particular, in the previous talk by Fabrizio, health outcomes sometimes have fallen, but or have improved or got worse. Fabrizio talked about it's generally accepted that traffic accidents, work-related injuries fall during a recession, but mental health issues, suicides go up. That tends to be what people believe, but beyond that, it's very controversial. It's very hard to be sure about the impact. So really what we wanted to say was be careful with the choices that you make over the next few years. Try and make the right choices, because the right choices are going to determine the impact on people in the future. So at that point, it was already clear that the recession was different. The recession originated in developed countries this time. It has implications for their own health sectors. There will be blips in growth in other countries, probably, but the main problem for the lower income countries was probably going to be the fall in donor assistance, if that happened. You probably forget that this crisis happened just after a global food crisis as well, so that if this crisis did affect low-income countries, it was going to exacerbate the food crisis. But the fiscal position at that stage of many of the developing countries in 2009 was much better than it was in the early 1990s. So many of the low and middle income countries were better placed to spend their way out of the crisis, if you like, if they were allowed to do so. And as we said, it was not yet a recession in the developing world. So let's just see what happened. What happened? Were those predictions right? This is the gross middle income, high income, low income countries using World Bank definitions. And as we said, the recession in the strict definition of, or one of the strict definitions of the term, happened in high income countries. There was a blip in middle income countries, but interestingly, low income countries continued to grow quite nicely. The recession didn't affect them in the way that other recessions have affected the low-income countries. Now, I'll come back to this because this has affected the psychology, if you like, of donor assistance, something that I think is a little bit dangerous, and that I'll come back to at the end. The other point to notice is that down in 2012, there was another double dip, if you like, in many countries, but not on average. As I said before, you're not expected to read all the details. This is just the Eurozone. And this shows you the point that I said earlier. There is a lot of heterogeneity. In the Eurozone, this is the annual change in GDP per capita, real GDP, inflation adjusted. The dark line is the growth rate from 2000 to 2008, and the grey lines are the growth rate in 2009. So you can see that even some of the European countries still grew in 2009, but most of them had negative growth rates. So these averages that I'm talking to you about hide a lot of variability across countries, and the individual country experiences are very important in this. And we do see, again, even in Europe, there's some countries that have actually done quite well during this crisis. The other interesting thing, again, as Fabrizio said, is that government debts are very different now in the rich countries. And you will have read a lot about it. The rich countries had to bail out the banks. The rich countries spent a lot. They printed money to spend, what they call a lovely term, quantitative easing, which means printing money. But what's the debt levels in the high-income countries are highest than they've ever been, ever. And again, this affects the psychology of the richer countries, the high-income countries. Interestingly, the debt levels of the middle-income countries have fallen. That's what I said. Their debt levels are relatively okay. The debt levels of low-income countries, the middle-income countries, sorry, this is middle income, this is the low-income countries. But the low-income countries have continued to reduce their debt levels. The middle-income countries reduced a little bit, but as the high-income countries, that their capacity to spend in the longer term and the psychology around that has changed quite a lot. What does this mean for how governments have spent? One indicator of fiscal space is government expenditure as a proportion of GDP. Right? A ratio is often very difficult to interpret. This is the share of GDP governments spend. So how much are they still able to spend even though they have to repay debt and service loans? And In this case, you will see obviously the government spending immediately went up because they had to bail out the banks, they had to prop up the economies. But then government spending, they've been desperately trying to reduce the share of GDP that goes in government spending ever since. And where GDP has declined in many countries, this share of government spending also falling means government expenditure is falling. As I said earlier, it doesn't mean government expenditure on health has to fall. It means government expenditure is falling. It's a choice variable what governments decide to do, how they decide to spend their money. Total health spending has continued to rise overall. Total health spending around the world continues to go almost out of control. It increases very rapidly in all regions. Again, just some numbers for a slightly longer period to show you that overall total spending on health has continued to rise very substantially. But public spending on health hasn't necessarily kept pace. Some countries chose to protect health, some countries chose not to protect health. And again, the negative growth rate in public spending doesn't mean that countries are actually spending a lower proportion on health. That if their government expenditure is going down, they might still be spending a higher proportion on health, but the total expenditure can still be going down. And these are the countries in the Eurozone that at some point reduced the absolute level of per capita government spending on health. So it's not terribly positive in some sense that even though we were arguing, and it's easy for me to argue because I don't have to run a country, even though we were arguing that you can protect health spending if you want to, the politics and the pressure in many of the countries in the Eurozone meant that virtually all countries in the Eurozone reduced their spending on health in at least 1 year. But as I say, some countries actually tried to protect health in terms of the share of public spending because government spending was falling, overall spending's falling, but people said, well, let's try and protect the social sectors and protect health. And in this particular case, you will see that almost all of the, well, more than half of the Eurozone countries tried to protect spending on health, which is what we were arguing in 2009. Again, total spending fell, but some of these countries didn't protect health. They actually reduced the proportion of government spending going to health. Some of these were recipients of EC or IMF loans. And that exacerbates the pressure on countries. Often, it's a debate that we've had with IMF for 25 years, and I haven't won it yet, that health is not just a consumption sector. The IMF and some ministries of finance tend to think that health is purely consumption spending. Okay? It's an obvious place to use to try and cut spending. Because it doesn't contribute to the economy, it just takes from the economy, is their argument. And we've been trying to argue that you miss the important effects of health, improving health, on economic growth if you do that. But it is where the IMF is involved in lending to countries, you will find often that expenditure or the share of expenditure on health falls because they use the health sector as a way of trying to get efficiency gain. Let's think about longer-term issues. I've focused largely on the high-income countries because that's where the main crisis is. But interestingly, there's been dips in growth rates in the middle-income countries. But if you think about employment, unemployment has gone up in some of the places that you wouldn't expect it to have gone up. And as Fabrizio said, there is a link between unemployment and health outcomes, certainly in some studies. Let me just take female, which is these two dots. The red bar is unemployment in 2014. The circle is unemployment, female unemployment in 2007. Okay? So in this Latin American and Caribbean, unemployment fell. But in some of the countries, developed as you would expect, they went up. The world, it went up. But interestingly, the Middle East and North Africa in particular, unemployment amongst women went up. We can't tell whether it's necessarily a result of the financial crisis, but it's associated with the financial crisis. This was not really expected when it happened. We didn't really expect that. And so we have to still say, okay, even though the Eurozone and the high-income countries are the ones that have been mainly affected, there have been spillover effects in other countries. Now, in many of these countries, as you will know, unemployment refers to the formal sector. Formal sector is relatively small. ILO has made a big point that the growth of formality, the growth of formal sector employment has actually slowed down. So the trend line above is the trend line for the formalization of the workforce before the crisis, and the blue one is the trend in the formalization after the crisis. So again, it's still growing. The formal sector is growing everywhere, but there's fewer people. It's a slower rate of formalization, so fewer people are finding work in other ways. So again, this is a way of thinking about there are other impacts of the crisis than we would have expected in 2009, things that we didn't really think about that are affecting usual people, normal people. What about the ODA? The development assistance. This is commitments and disbursements. This is not necessarily what's arrived in the countries. This is what donors report. And I've only taken the 37 donors for which there is consistent data across that time period. Some of you will have seen that Chris Murray recently from IHME in Seattle had a big report that says donor assistance for health hasn't fallen. It's a very difficult thing to say because over this period there's not a consistent set of donors reporting. So your total health ODA hasn't fallen if you just add up the ODA by year, but you've got a different set of donors reporting in the recent years. So that's one of the reasons why health ODA doesn't seem to have fallen. But for me, the blue one is the one that you need to look at, commitments. This is the promises that donors make to countries. And that's what is worrying. The disbursements, the promises are long-term promises, so they're not necessarily guaranteed in any particular year. So the disbursements can be linked to previous promises. They're not necessarily linked to this year's promises. But the promises that donors have made since the financial crisis have actually declined. And you do start seeing that. This is from the National Health Accounts data, what donor assistance reaches countries, and you could see that after the financial crisis there was a decline. It did increase again in 2011, and then it fell down again. So this is linked to what I said earlier. Even if donor assistance, even if donors don't want to spend more on ODA, they don't have to spend less on health. It's a choice variable. How much do they give to health? And interestingly, the commitments to health have fallen, right? But at the moment, there's sort of some worrying signs that actually the payouts to health in low-income countries are also declining as a result or subsequent to the financial crisis. One other problem with the aid, and this is just, what are these countries, these 4 countries that I've picked out? Why did I pick those 4? All right, these are the Ebola countries. And so it's just interesting to look at the aid that's gone to the Ebola countries over the last few years. This is just typical. But most of the aid has gone on MDGs 4, 5, 6. AIDS, TB, malaria, maternal, child and reproductive health, with a large proportion on child and reproductive health. Almost nothing, very little, to strengthening health systems. And it's really clear that those health systems haven't been able to deal with the Ebola crisis. Those health systems have been very, very unable to deal with an outbreak that should have been possible to control. And the nature of the aid has also changed. The nature of the donors' commitments to health have also changed. Let me just think about what the implications of all of this, try and tie it all together. Recession, in the formal definition of the word, of two periods of growth, has been largely in the high-income countries, although some of the middle-income countries, particularly in the Eurozone. This has reduced national incomes, increased unemployment, and increased income inequality. I haven't talked much about inequality, but if you're interested, OECD just brought out this year a nice study of the economic crisis, where they're arguing that in all of the recent economic crises since 1990, income inequality has increased, and income inequality hasn't got back in periods where the crisis of periods of growth. Now, whether it's due to the crisis or not, as Fabrizio says, it's difficult to prove, or whether it's due, in my country, to, I'm Australian if you haven't told by the accent, in my country we have a right-wing government that's dedicated to increasing inequality. Am I allowed to say that? Whether it's the crisis that's led to it or the government policies that have led to it is another question that can't be answered. Most of the Eurozone and high-income countries reduce government spending on health, not all, and some of them actually increase the proportion of government spending that goes to health, even though it fell. So some countries really took active efforts to protect health. But it's still a choice variable, and why some countries chose to reduce health spending and the proportion to health, and why they didn't, is a political decision that, again, I think some of you will be better able to answer than me. In thinking about efficiencies and reducing government spending, most of the European countries, if you think about the universal health coverage cube, took steps on all three parts of the cube. Some of them reduced the population that was covered by social health insurance or benefits. Some of them reduced the services that were available, and some of them increased out-of-pocket payments. Okay? The net impact of that on out-of-pocket payments and household expenditures is difficult to determine. It's a little bit like the health impact, partly because you rely on household surveys to get those data, and many of those countries haven't had recent household expenditure surveys where we can see whether the impact on impoverishment and financial catastrophe is increased or decreased. So that's something that we have to keep an eye on for the future. There have been major attempts to increase efficiency in health, but again, it's very difficult to tell at the moment what's succeeded and what hasn't succeeded. It's something that really is begging for good research. But there have been substantial flowovers in other countries. Growth fell substantially in some middle-income countries, but not in the low-income countries. There's been some increase in unemployment in places that we didn't expect it. There's been a fall in the rate of new people getting jobs. So that this reduces your capacity to raise funds. As those of you that are attending the financing short course know, it's much easier to raise funds when people are in formal employment than it is when people are in informal employment. There's no evidence in the low and middle income countries of general falls in health expenditure, although again there's no evidence of increased government commitment to health in terms of the share of health spending going to the share of government expenditure going to health. It's sort of been business as usual really in the low and middle income countries. But there's falls in donor commitments to ODA, and some falls recently in receipts in sub-Saharan African countries, although I'm sure the Ebola crisis will show next year there's been another jump as people go in, particularly into the Ebola-affected countries with foreign aid. But let me just finish on, I think there's been a major change in sentiment around ODA and donor assistance. Those of you that can think back to 2000 and the Millennium Development Goal will remember the enthusiasm with which the world, and the donors in particular, embraced the need to help countries achieve the Millennium Development Goals. Massive increase in external assistance, particularly for health. This has changed. The last 3 or 4 years, what I hear is, okay, the low-income countries are growing quite well. They have to take on a bigger share. We have problems. we are going to cut back. And so the focus is not on helping the poor, reducing inequalities, improving health. The focus has been on sustainability, affordability, efficiency in the low-income countries. And that changes the dynamics of aid. So more and more donors are asking for counterpart funding, for example. Okay, I'll give you aid, but only if you fund the same things as I fund. So this nature of the aid, the nature of the psyche, and obviously the politicians in the rich countries are responsible to their taxpayers of how they use the money. So they're thinking about, okay, how do I convince the taxpayers that I need to give money to those people where their growth is positive and our growth is not positive? And that's what some of the people see. And I think that over the next few years, this is really one of the problems. The concentration of the aid on the diseases and conditions that were in the MDGs, rather than on strengthening the capacity of health systems to deliver people-centered care and services, prevention, promotion across the lifespan, I think is something that people are needing and starting to think about with the Ebola crisis as well. And that, I think, is something that we've got to worry about again over the next few years. So I hope that's given you some idea of what we know and what we don't know about financial flows and the crisis, who's affected and who's not affected. And as I say, I'm very interested to hear experiences of the different countries around there in the room. So thank you very much for your attention.
So thank you very much, David, for this nice talk. So both speakers put on the table a number of interesting and controversial issues. So let's open the debate. Can I start, if there is, to break the ice? I think it would be very interesting to also reflect a bit on what we can do as a public health community to help policymakers to face the challenges that the economic crisis is posing to health and health systems in particular in countries that are most affected by the crisis. So is there any lesson we can learn to help policymakers to do better in managing the crisis? Or is there any opportunity in the crisis to maybe improve the efficiency of our health systems? So, David, you can.
In some ways, I'd like the input of some of the countries, particularly in Eastern Europe, that have tried to do this, because there's been a lot of attempts to say, okay, now is the chance to improve efficiency. Sometimes they do it by paying health workers less, which I think is not necessarily a good way of improving efficiency. But I think it's just a little bit too early. I think the opportunities, for example, people use Thailand in the Asian crisis of the late 90s as an example of a country that used the crisis as a way of introducing their universal coverage system, because they noticed that in their crisis it was the poor that were suffering and the poor that were not able to get health services. So they used that political agitation to introduce a universal coverage scheme for the poor. And that was a major advance. At the same time, they did a lot of things to improve the efficiency. So they changed the way doctors were paid, for example. They changed the way hospitals were paid. They gave incentives for efficiency. But I think at the moment there's too few examples that have been closely studied in this crisis for us to be able to say, well, countries did well in improving efficiency. They certainly cut costs, but I would be interested in whether people around the table have a more hands-on experience on that.
So Fabrizio, do you want to add?
No, maybe I'm thinking of the United States. No, it's one of these countries where at least they are trying to increase the universal coverage and improve efficiency. But I don't know what is going to be the final results. Maybe you can say a bit more on this.
Are there Americans in the room?
Yes. They don't say. They don't.
I mean, you're right.
I can tell you yes.
You're right that it was the sort of crisis that enabled it almost to get through the legislation. Whether there's been a great commitment to improve efficiency linked to the payment mechanisms, overuse, etc., in the US is debatable. There's certainly been a lot of attention to try and make sure that people that were not covered by a form of financial risk protection are covered, which is a good thing as well. So that's linked to one part of financing, more the out-of-pocket payments, financial risk protection part, which I think is an important opportunity here as well.
Okay, so there's a question there.
Thank you both of you for your very interesting talk. And I would like to challenge you a little, because I'm grown up in a period where an ultrasound scanner was a new thing. I basically was there when those instruments were born. I was there when the first MR scanners were developed. Today, our diagnostics, our hospitals are as advanced, as cheap as never before. But traveling through Europe, being part of the Commission activity on active and healthy aging, I have in front of me the strategy, which is innovation and kind of sharing our innovations through Europe. In periods where we all are well and doing well, of course, we will develop our national e-health systems, we will develop our national middlewares in all kinds of flavors, and we will never think about to share anything. Isn't it worth now looking into what goes into real patient treatment and what goes into administrative, e-health, telehealth, mobile health activities, and what of those really counts? Because every government I meet, they think technology is a total solution. But wherever I go, diagnostics and money for the patient is reduced. Thank you.
Okay, thanks. Let's collect a few questions and then.
Thank you very much, sir. I'm particularly happy with the, that statement.
Can you just say who you are?
My name is Evelyn Ananisapon, and I come from Ghana originally.
Okay, thanks.
I am particularly happy with that slide that showed a fall in donor support and a stubborn hesitancy of the low-income countries' development and growth to go down. It is a positive evidence of the problems of dependency, even when it is something you cannot do without. You see, when the money is not coming, it forces you to be more innovative. It forces us to start considering a lot of things. We have fewer conditions to meet. Many times when you depend on, say, 3 donors, each of them comes with its own conditions. The difficulty is the donors themselves don't work to see what works together. They expect the recipient to see how to satisfy the different conditionalities they are coming with and still achieve what they would have achieved as one person. And so I dare say that, yes, we have our difficulties, and donor support as it goes down and the requirements for self-sufficiency are in the short run going to affect us and make difficult decisions difficult to take. But in the long run, it would remove the dependency that we are in now. It will help people have the confidence to take bold decisions, be able to take risky decisions, because you don't have to answer to someone if you fail, you know. And we are going to lose lives, that's one thing. We are going to suffer in the short term. But over time, I think that those who are morally obliged and will support us will help us see faster growth than continuing to be dependent. Thank you.
Thank you very much. Let's take another one before.
Hi. You mentioned that with your conversation with the IMF, you had difficulties about linking health expenditures with economic growth in a way. And I was thinking, why? Because I felt that was quite documented that increased level of health has actually an impact on employment, on household incomes. So I was thinking, what is the difficulty in the conversation with the IMF, for example? What are the arguments against it?
Okay, because for me it's easier to discuss about, Evelyn is your name? Yeah, okay. And the point on the fact that when the money from donors comes down, it's a sort of incentive to improve efficiency, and maybe in the long run can have positive effect. I partially think like you, there is an important economist slash demographer slash social scientist like Deaton that in a recent book probably pointed out exactly this point. Sometimes there are so many programs, tons of programs by different donors that sometimes are also interested, no? And I don't want to stress too much the point of interest. And this program goes in different direction, and so they are not efficient. Sometimes it's better that the country try itself to improve this condition without relying always on money comes from abroad that are conditional and sometimes are not efficient because they go in totally completely different direction, and maybe they do not improve the general condition of the country. I agree partially with you.
On the first one, I think just as a general comment, I think the crises do require governments and everyone to think about tightening a belt. Tightening your belt in that sense can come in many ways. It can come through cutting expenditure, and many countries just react and cut expenditure. But it can also be on a serious evaluation of how to get more efficient, use the money better. And you were talking about that in some sense of how do you use the money better rather than just the sort of, okay, we have to slash spending. How do we use it better, and how do we make sure that the system is more efficient in the future? And I think some of the countries have tried to do that. But I don't know the case of technologies terribly well. But I think what you were talking about, e-health, m-health, that sort of thing, are also ways of trying to set a system up for the long run and share experiences across countries. We have a project at the moment where we've been trying to gather from not just high-income countries but everywhere examples of how countries have tried to get more efficient in their health systems. Because you might remember from the World Health Report of 2010, we estimated that somewhere between 20 and 40% of all health expenditure was wasted. Okay, now that's quite a straightforward calculation, even if it's a little bit back of the envelope, but doing something about it is not straightforward. It's full of political problems. And so we thought, okay, to build on that, let's find some examples where countries have tried to become more efficient. Let's evaluate it, let's encourage researchers in that country to evaluate it. And if it worked or didn't work, we need to report that and share those experiences. And so I think it's a little along the lines that you're saying, because there are some good experiences out there, but mostly they're in the heads of government officials who have done it, and no one else really knows about it. On the aid, I won't go into the aid issue because Fabrizio has responded a little bit, but yeah, there's pros and cons, obviously, and you know, as a department in WHO where I have to raise external funding from donors to pay my staff, some, I don't know, 10, 15 million a year, I know the problem of being dependent on a few donors. And so it's sort of, you know, I'm not trying to belittle the problems of a country, which are much more important, but there are pros and cons of accepting the aid. The downside is that at the moment, even with good growth rates, most of the low-income countries are not going to reach an adequate level of spending from domestic sources for the next 20, 30 years. And so it really is a political decision at home. How rapidly do countries want to move towards universal health coverage? Will they accept a slower growth because they'll use their own resources than if they use external resources that can mess up their own systems to some extent? So that's a political decision for countries to make. I can't comment on that, but there are pros and cons, as you, Evelyn, pointed out so strongly. And then the IMF, I don't think anyone disputes that good health is positively associated with economic growth, although there are sort of debates about causality, but I think most people will accept that you can show that improving health leads to economic growth. What is disputed is, does health spending lead to improved health? and does government health spending in particular lead to improved health? And there's been a lot of studies out of the bank and IMF that suggest that government health spending hasn't led to improved health. Now, they're fraught with all sorts of problems because it really obviously depends on what type of spending. You know, bad spending won't improve health. Inefficient spending won't improve health. But some sorts of spending will improve health. So getting vaccines to kids that need vaccines improves health. You can't dispute that. So it really is a debate about will government spending in particular improve health, or is government spending wasted? And I think we all acknowledge that government spending and other spending, private spending, some of it is inefficient, some of it is unnecessary, and it's really dealing with that while at the same time focusing on the things that improve health that will get the health improvements and the growth. But that's a debate that's been going on for a long time.
I had a point on this last issue, because the story about whether health expenditure increase health or not, it depends on which part of the health expenditure we are looking at. So if we look at the growth in health expenditure in the United States and you look at the health outcome of the United States, probably you don't find this close correlation between health outcome and expenditure. Because in the United States, the growth in health expenditure was driven by increases in prices of medicine, prices of doctors. So it's not related with the quantities provided, it's not related with, or maybe inefficient quantities, so extra and inefficient treatment for people that are rich, and so not for people that are poor and that need more an help on the health side. So it depends on which. What are the major drivers of the health expenditure? Whether we look at prices or whether we look at quantities and quality. So these are two different sides.
Okay, is there any other questions? Yes, first.
Okay, thank you very much. My name is Aweneni Mangombe from the Republic of Zimbabwe. Evans, your last point or comment was talking about these donor commitments also relying from a political side of things. And I want to agree with you. But my comment is a follow-up to the issues of sustaining the donor commitments. When these donors are coming, for example, to a region or a country, do they come up with an exit strategy that even also prepares every country or a region that is receiving that donor support to be prepared sustainably to maintain the results or the benefits of that donor support? Maybe it's a question that we even need a research or a study to assess even the regional commitments. I know from where I'm coming, Zimbabwe. Zimbabwe is a member of the SADC community, and there is already a commitment that talks about the SADC members to commit about 15% of their annual budgets towards health financing. And I'm sure if these donor commitments would come to enforce those kind of already existing systems, I'm sure that will create even a balance in terms of maintaining benefits and results on health indicators. So my question, perhaps if it's a comment rather, is has there been any analysis of exit strategies for these donor commitments? If so, how are they balanced with the already existing country or regional commitments on sustaining health, especially in the low-income countries where I'm coming from? Thank you.
Thank you very much, Luca. So maybe while Mike comes here, if I can comment on one aspect is that I'm a bit concerned that the crisis might be used by governments of countries with universalistic health systems to reform the system and to go away from universal health coverage. And I'm a bit afraid that people may lose trust in these universalistic systems if spending cuts got to the point that people feel that they don't get what they should get. So my comment is really, what can we do to help policymakers, in particular in countries that are seriously affected by the crisis, but that still have a universalistic health system, to maintain these systems? So Luca, sorry.
Yeah, David, I would like to come back to the book by Deaton, because the critique with respect to ODA was very strong. First of all, it's very difficult to find evidence that higher ODA had a positive impact on growth rate. And the reason is that many times this aid is linked to a political agenda. Many times reduce electoral accountability of governments, of non-democratic governments, so there is a point. But then Deaton raises a question, maybe in health is different. Maybe we should at least protect ODA in health. And the point he made, and I would like to hear your point on that, is that many times you observe like a crowding out. So you increase the health spending through ODA, but at the same time the government reduces its own spending on health. So the question is, do you observe a positive correlation between the total health expenditure and the level of ODA in health? And the second point, if you are not strengthening the system, sometimes what happens is that I don't know, with the new private funders, no? So you run a very good hospital in a district, and you attract all the educated doctors and nurses in this hospital, but you leave other part of the country without, if you don't invest, for instance, in education of workforce. So what is your point? Is this critic of Deaton right, partially right, or you have a more positive view?
Okay, let's take the last question and then we give the opportunity to the speakers to reply. Yes, Marisa. Oh, then the last two. Okay, sorry about that.
Hi, my question is just very simple. I'm originally from Canada, and of course we have a universal health system. So my question was just about cost cutting, because of course in Canada we're really in the process of a lot of reformation around, for instance, reducing the number of registered nurses and replacing them with licensed practical nurses and so on. So my question was just, is there been a lot of research done looking into how the cost cutting might have long-term effects or even short-term effects on health outcomes? And if this actually has an effect in the long term or short term on decision making as well.
Thank you very much. And last question.
My name is Christian from Switzerland. I think health is also an industry, and I would be interested how much of the ODA comes back to the donor countries, for example, to the pharmaceuticals.
Okay, thank you very much. Maybe Fabrizio, do you want to start, and then we'll leave maybe the last word.
Competencies can help mainly in one of the last question about the effect of health expenditure cuts on population health. Maybe this is the question, no? You were raising. Yeah, unfortunately there is not so large evidence in developed economies, but we have something that I shown before on Mexico or other developing economies. And I think that crucially depends, okay, as I said before, on the level of economic development of a country, but also on the type of the recession. So because usually the recession in developed economies are so small that you cannot observe real cuts in health expenditure. This time, so it might be it's different because we already observe in many also European countries cuts in government expenditure, and I'm afraid to say that probably you're going to observe negative effects that are in some way similar to what we see in Mexico, at least in some countries. From this point of view, in a series of, in one of the paper before this discussed of Stagler and co-author, that also wrote a book on the effect of the last recession, they also pointed out that at least in Greece and in Spain, I'm not sure, I have to check it, they found an effect of health expenditure on health. But as I said, it's too early to find and to look for these effects.
On the Zimbabwe question or comment, 2 points. That the commitment that the presidents of the African, or the heads of African states that were members of the African Union in 2001 to give their 15% of their budgets to health basically hasn't been honoured. If you look at the data, almost as many African countries have moved further away from the 15% as has moved towards the 15%. And we met with the ministries of finance of the African Union 2 years back, 2 years, 3 years, and they were basically saying, don't talk Abuja Declaration to us. You know, we didn't do that. That was our presidents. All the presidents are gone. We don't believe in the 15%. So it's really very hard to get most ministries of finance to accept that Abuja Declaration means something for them. Ministries of health still use it, and we try and help them use it as a way of increasing expenditure on health. But again, sort of thinking about increasing expenditure on the right thing. The exit strategy thing is useful. The complication in health is that because of the aid, as I showed you, is so sort of focused with particular programs, each program wants its own exit strategy, and they don't combine. And you can't have an exit strategy where the donor picks, where the host country picks up everything in the next 4 or 5 years. It's not going to be possible. And yet each of the individual programs often expects the country to pick up their expenditure. And that's why with the principles of the International Health Partnership are trying to be used to sort of say, okay, buy into a country's plan, buy into a country's processes, and help think across everything so that exit strategies are for aid in general, but not necessarily for your part of aid. And that's a difficult discussion. But I think it's a good point that's getting more important. The crowding out of ODA, yeah, there is a positive correlation between ODA for health and total health spending. It's not a one-for-one. So there is fungibility so that countries that get a lot of aid choose to spend less of their own resources on health, but it's still a net increase. Interestingly, that net increase is less for budget support than for project support, which sort of worries me a little bit because countries use less of budget support for health than I would have anticipated. But there is a net increase. And again, does it improve health? It depends how it's used. And you're right that we have classic examples of big teaching hospitals built that absorb all of the staff of a country, and there's no staff left anywhere else. And I think that this need, I mean, I didn't mention it, but I think that the other, apart from self-sufficiency, the key word that's coming back again and again from donors is results. But results short-term, right? By strengthening a health system, you don't get results short-term. To train health workers, you don't get them short-term. And if you want short-term results that you can persuade your Prime Minister or President that you've saved 1 million children's lives, you're not going to do training health workers because it takes you too long. And again, this short-termism now of aid is a problem in my perception, that we need to sort of get back to saying, okay, we do need quick wins, we can do some things quickly, but if we don't strengthen the whole system, we're not going to get there. On the final...
Sorry, do you have any idea of any measure of crowding out, whether for each dollar of donors we have a reduction of, let's say, 20 cents or 25? Any idea?
It's bigger than that. It's around 80 cents.
Oh my God.
So it's a 20% net increase, there or thereabouts. Depends on the country, obviously, but it's not 80 cents.
Ah, okay, so it's a lot.
But am I worried about that? No. Depends. Depends where it's being spent. So where is the government putting their money? And we don't know. And I have a little project going on at the moment that says, okay, in the countries where they've used aid fungibly, where has the government put its money? It's not an easy question to answer econometrically. But if they're spending on education, if they're spending it on water and sanitation, if they're spending it on social sectors, might have a bigger increase on health than spending on health services. So I'm not so worried about that. but we don't really know where they're putting it at the moment. And give me a few months. On Canada, the cost cutting, I don't think there's good evidence in rich countries of what the long-term impact on cost cutting is. There is good evidence that where cost cutting is accompanied by increases in out-of-pocket payments, that utilization, unless safety nets are very effective, utilization amongst the poor falls. Completion of long-term therapy falls. So that there is good evidence on that from many different settings. So it really depends how that cost cutting is done and what the social safety nets are like. And then finally on the ODA to donor countries from Christian, there's not good figures on that. The Development Assistance Committee in OECD, where donors report, they did have a category on technical support, which often was to using consultants from their own countries of the aid, but that has fallen out of the system now. So it's even not easy to see how much goes in technical support as opposed to aid the countries can use. The best thing we do is compare the OECD data on disbursements with the data that we get from national health accounts of how much arrives in the country for them to spend. The difficulty with that is that not all donors report to the OECD. So in some countries we actually find more arrives in the country than actually is reported to the OECD because they've got a donor that's not reporting to the OECD. So it's a long way of saying, unfortunately, we don't have good data on what you're suggesting. And the tied aid, you know, when some donors say, okay, here's the aid, but you can only purchase from our country, again, you have to go into all of the aid documents, and I think some of the NGOs do that, but I don't have good data on that.
Okay, thank you very much, David and Fabrizio, for the nice talks and discussion.